Good morning, everyone, and thank you for joining me today. We're going to dive into an important topic in respiratory health: ventilation-perfusion relationships and their clinical implications. This presentation will help us understand how gas exchange works in the lungs, explore the underlying pathophysiology, and review how these processes are measured in pulmonary function. I'm excited to take you through these key concepts that are crucial for both diagnosis and treatment in respiratory medicine. Let's get started. In Chapter 12, we're going to explore the concept of ventilation-perfusion relationships. This is a fundamental topic in understanding how air and blood flow work together in the lungs to ensure efficient gas exchange. We'll look at how ventilation, which is the movement of air into and out of the lungs, matches up with perfusion, the flow of blood through the pulmonary capillaries. Understanding this balance is crucial because any mismatch can affect how well oxygen gets into the blood and how carbon dioxide is removed. Throughout this chapter, we'll dive into the mechanisms behind this relationship and its significance in respiratory physiology. When we talk about normal gas exchange, it's important to understand that it depends on the pulmonary blood flow reaching ventilated alveoli. In other words, air needs to reach the alveoli, and at the same time, blood needs to flow through the surrounding capillaries to pick up oxygen and get rid of carbon dioxide. This is where the ventilation-perfusion ratio, or VQ ratio, comes into play. It measures how well the amount of air reaching the alveoli matches the blood flow in the pulmonary capillaries. A balanced VQ ratio is essential because it ensures that gas exchange is efficient, allowing oxygen to enter the blood and carbon dioxide to be removed properly. Without this balance, normal gas exchange can be significantly impaired. When we talk about ventilation perfusion, or VQ, we're looking at the relationship between the air reaching the alveoli and the blood flowing through the pulmonary capillaries. At rest, the alveolar ventilation is about 4 liters per minute, which means this is the volume of air available for gas exchange each minute. Meanwhile, perfusion, or the blood flow through the lungs, is a bit higher, around 5 liters per minute. When we compare these two values, the overall VQ ratio comes out to about 0.8. This ratio is crucial because it reflects how well ventilation matches perfusion, influencing how efficiently oxygen enters the blood and carbon dioxide is removed. Understanding this balance helps explain normal lung function and what might happen in various respiratory conditions. When we talk about ventilation and perfusion, we're referring to two key processes in the lungs. Ventilation, represented as V, is the amount of air that reaches the alveoli each minute. On average, at rest, this is about 4 liters per minute. Perfusion, or Q, is the blood flow through the pulmonary capillaries, which is roughly 5 liters per minute at rest. The ratio of ventilation to perfusion, or V over Q, is important because it reflects how well air and blood are matched for efficient gas exchange. For the entire lung, this ratio averages around 0.8, indicating that perfusion slightly exceeds ventilation under resting conditions. Understanding this balance is crucial for recognizing how the lungs optimize oxygen uptake and carbon dioxide removal. Let's take a closer look at ventilation and perfusion in the lungs. On average, the alveolar ventilation, which is the amount of air reaching the alveoli per minute, is about 4 liters when at rest. Meanwhile, the perfusion, or the blood flow through the pulmonary capillaries, is slightly higher, about 5 liters per minute. When we compare these two, the ventilation to perfusion ratio, or V over Q, comes out to roughly 0.8 for the entire lung. This ratio is crucial because it reflects how well air is reaching the blood for gas exchange. A balanced VQ ratio ensures efficient oxygen uptake and carbon dioxide removal. The ventilation-perfusion ratio, or VQ ratio, is fundamental in controlling the partial pressures of oxygen and carbon dioxide within the alveoli. When ventilation and perfusion are well matched, the alveolar PO2 remains high, which is essential for efficient oxygen transfer into the blood. However, if the VQ ratio drops, meaning ventilation is low compared to perfusion, alveolar oxygen levels fall while carbon dioxide levels rise, which can lead to hypoxia. On the other hand, a high VQ ratio indicates more ventilation relative to blood flow, resulting in higher alveolar oxygen but lower carbon dioxide. Imbalances in this ratio often occur in lung conditions like obstructive or restrictive diseases, disrupting normal gas exchange and impairing oxygen delivery to the tissues. Understanding this balance helps us grasp how different pathologies affect respiratory efficiency. When we talk about abnormal gas exchange, there are a few key mechanisms to understand. First, overall hypoventilation happens when ventilation is insufficient, meaning the lungs aren't moving enough air in and out. This leads to lower oxygen levels in the blood, or hypoxemia, because not enough oxygen is being brought into the lungs. Next, we have the absolute shunt. This refers to parts of the lungs where blood flows through without picking up oxygen at all. Essentially, some blood bypasses the oxygenation process, which also causes hypoxemia. Lastly, there's the ventilation to perfusion mismatch, or VQ mismatch. This occurs when the balance between airflow and blood flow in the lungs is off. For example, areas getting plenty of air but little blood, or vice versa. This imbalance impairs how effectively oxygen gets into the blood, again leading to low oxygen levels. Together, these mechanisms highlight why gas exchange can become abnormal and why oxygenation suffers. When we talk about hypoventilation, it's important to understand how it impacts gas levels in the body. Unlike other respiratory problems, hypoventilation specifically results from inadequate ventilation mechanics. This means the lungs aren't moving enough air in and out, which leads to a distinct type of low oxygen in the blood. Now, when it comes to treating this condition with oxygen therapy, we need to be careful. Simply giving oxygen might improve symptoms temporarily, but it doesn't fix the core issue, the poor ventilation itself. So, oxygen treatment should be part of a broader, more comprehensive approach to managing the patient's respiratory function. When we talk about an absolute shunt, we're describing a situation where ventilation either stops completely or is severely reduced, while perfusion, the blood flow, remains normal. This means that blood continues to flow through the lungs, but there's little to no air reaching the alveoli. In terms of the ventilation-perfusion relationship, ventilation is less than perfusion. Essentially, the lungs are receiving blood, but not enough air is reaching the alveoli to oxygenate that blood. The critical point here is that the blood doesn't come into contact with alveolar gas. Without this contact, gas exchange can't happen, so the blood remains poorly oxygenated as it passes through. This condition is often associated with serious lung issues like severe pneumonia, pulmonary edema, or atelectasis, all of which can block or collapse alveoli, preventing proper ventilation. Finally, the big question is whether treating this condition with supplemental oxygen would help. In absolute shunt cases, simply increasing oxygen levels often won't be enough because the blood isn't reaching ventilated alveoli to pick up that oxygen. So, understanding this helps guide effective treatment strategies. When we talk about VQ mismatch, we're referring to a situation where the patient's lungs receive blood flow or perfusion, but the ventilation is compromised. In other words, the amount of air reaching the alveoli is less than the blood flow, so ventilation is less than perfusion. This imbalance means oxygen isn't efficiently getting into the bloodstream. This is sometimes called a relative shunt because it mimics the effects of a true shunt, where blood passes through the lungs without getting oxygenated. But in VQ mismatch, the issue is ventilation being impaired rather than an anatomical shunt. Common causes that lead to this kind of mismatch include conditions like asthma, obstructive lung diseases, cystic fibrosis, and even mild cases of pneumonia. These diseases interfere with airflow, reducing ventilation in certain lung areas. Finally, when considering treatment, one key question is whether providing supplemental oxygen will help. Since there is still perfusion occurring, increasing the oxygen concentration can often improve oxygenation despite the ventilation problem, but this depends on the severity and nature of the underlying cause. Here, we're looking at a concept called dead space. This occurs when ventilation, or the air reaching the lungs, is normal, but perfusion, which is the blood flow to those areas, is either absent or significantly reduced. Essentially, air is getting into the lungs, but there's not enough blood flow to pick up the oxygen. This mismatch between ventilation and perfusion is what defines dead space. In this situation, ventilation actually exceeds perfusion, meaning there's more air than blood available for gas exchange. Understanding this imbalance is key because it helps explain why oxygen delivery to the body might be compromised even though the lungs seem to be functioning well in terms of airflow. Common causes of dead space include pulmonary embolism, where a blood clot blocks the flow of blood to parts of the lung that are still being ventilated. Other factors like low blood pressure or cardiogenic shock can also reduce perfusion, making the problem worse. Recognizing these conditions is important for diagnosing and managing patients with respiratory difficulties. When managing hypoxemia, we start by addressing hypoventilation, which often requires mechanical ventilation or non-invasive ventilation to improve oxygen intake. Next, we look at ventilation-perfusion mismatch, which is actually the most common cause of hypoxemia and typically responds well to oxygen therapy. Then, we consider intrashunting, which is a more serious condition where blood bypasses oxygenation in the lungs. This requires alveolar recruitment techniques like CPAP or PEEP to reopen collapsed airways and improve oxygen exchange. In some cases, despite intervention, hypoxemia can be refractory, meaning it resists treatment, often due to severe shunting. Finally, a general high-level approach focuses on improving overall oxygen delivery and lung function, ensuring that oxygen quality and uptake are optimized throughout. Shunt indicators are essential tools used to evaluate how effectively the lungs transfer oxygen from the alveolar air into the bloodstream. Essentially, they give us insight into how well the respiratory system is functioning. Some common examples of these indicators are the alveolar arterial oxygen gradient, or P, AaO2, the ratio of arterial to alveolar oxygen pressure, represented as PaO2 over PaO2, and the PaO2 to FiO2 ratio. These measurements help us quantify the extent of the shunt. It's important to understand that the larger the shunt, the less effective oxygen therapy tends to be, meaning patients with significant shunting may not respond as well to supplemental oxygen. Overall, assessing these shunt indicators allows us to gauge the efficiency of oxygen movement from the lungs into the blood, which is a critical factor in monitoring and managing respiratory health. The AA gradient, or P, AaO2, is an important measure we use to evaluate how well oxygen is being transferred from the lungs to the blood. Essentially, it tells us about the efficiency of oxygen exchange. Under normal conditions when someone is breathing room air, we expect this gradient to be between 7 and 14 mmHg. However, when a person is on 100% oxygen, the normal range increases, typically falling between 50 and 60 mmHg. What's crucial here is that the AA gradient has a direct relationship with intrapulmonary shunting. This means that, as the shunt increases, when blood bypasses the lungs without gas exchange, the gradient widens, indicating a problem with oxygenation. Understanding these values helps us assess and manage patients with potential shunting issues more effectively. The AA ratio, which stands for the ratio of arterial to alveolar oxygen partial pressure, essentially shows us the efficiency of oxygen transfer from the alveoli into the arterial blood. It's a key measurement because it reflects how well the lungs are oxygenating the blood. One important thing to note is that the AA ratio is more stable compared to the AA gradient, especially when the patient's inspired oxygen concentration changes. This stability makes it a reliable indicator in varying clinical conditions. Normally, we expect the AA ratio to fall between 0.75 and 0.95. If we see this ratio decrease, it suggests that there is some degree of intrapulmonary shunting happening, meaning that part of the blood is bypassing oxygenation in the lungs, which can be a critical finding when assessing lung function. The PaO2 to FiO2 ratio, or PF ratio, is a key clinical measurement we use to assess respiratory function. Essentially, it helps us understand how well oxygen is being transferred from the lungs to the blood. Normally, this ratio falls between 380 and 475, indicating good oxygenation. One of the advantages of the PF ratio is that it's straightforward to calculate. You don't need to go through complex steps like solving for the alveolar oxygen pressure. However, it's important to recognize its limitations when using it as an indicator of shunt. The PF ratio can be influenced by changes in carbon dioxide levels, specifically PaCO2, which means it doesn't always reliably reflect the extent of intrapulmonary shunting. That said, when we do see a drop in the PF ratio, it usually signals an increase in shunting within the lungs, which can be a critical sign in patient evaluation. When we talk about the clinical measurement of shunt, there are a few key parameters to keep in mind. First, values like P, AaO2, PaO2 PaO2, and PaO2 FiO2 are commonly used to assess gas exchange efficiency in the lungs. These parameters are particularly useful because they focus specifically on the pulmonary system. It's important to note that these measurements reflect lung function without being influenced by other systemic factors. However, one limitation is that they do not account for cardiac output, meaning the heart's role in circulating blood isn't factored into these calculations. Despite this, changes in cardiac output can still indirectly affect oxygen levels. For instance, a significant drop in cardiac output can lead to lower PaO2 values, impacting the overall oxygenation status of the patient. Understanding these nuances helps us interpret these measurements more accurately in a clinical setting. The Shunt equation, noted as QS over QT, is a fundamental tool for assessing pulmonary function. It takes into account various factors influencing arterial oxygen pressure, or PaO2, considering both lung-related and other systemic contributors. Measuring the shunt is essential because it reveals the actual portion of cardiac output that bypasses the ventilated areas of the lungs. In other words, it tells us how much blood flows through the lungs without participating in gas exchange. Clinically, this measurement is vital for identifying ventilation-perfusion mismatch, which helps us understand and evaluate conditions where oxygenation is compromised. For those interested in a deeper dive into the shunt mechanism and its clinical implications, I recommend consulting clinical focus boxes 12.7 and 12.8, which offer comprehensive explanations and insights. When we look at shunt fractions and their clinical significance, it's important to understand how these values correlate with the patient's lung function and the level of care needed. Starting with low shunt fractions, those under 10%, these typically indicate no significant clinical effect. In other words, the lungs are functioning well and oxygen exchange is happening normally. Moving up, mild abnormalities, which fall between 10 and 19%, suggest some intrapulmonary issues. Although there's an abnormality, it rarely demands intensive ventilatory support, so patients often manage without aggressive interventions. When shunt fractions reach a moderate level, between 20 and 29%, this signifies a more serious problem. Here, the patient usually requires ventilatory assistance, often involving positive end expiratory pressure or CPAP to help maintain oxygenation. Finally, high shunt fractions of 30% or more point to severe lung disease. This is a life-threatening scenario that necessitates aggressive mechanical ventilation, especially with PEEP, to support the patient's breathing and oxygen levels. Understanding these gradations helps guide treatment decisions and anticipate the level of respiratory support necessary.